Good evening, everyone. My name is Bethany Yeiser. I am president of the CURES Foundation. CURE stands for Comprehensive Understanding via Research and Education into Schizophrenia. And I am very happy to welcome you tonight to our lecture series. We have a very special guest tonight who is a CURES board member, Dr. Rajiv Tandon. He is professor and chair emeritus at the Western Michigan University Homer Stryker College of Medicine. He is an internationally renowned psychiatrist, educator, and researcher. So welcome, Dr. Tandon. We're very happy to have you.
Thank you, Bethany. Good evening, everybody. I'm going to try and keep the presentation relatively short, relatively brief, so that we have plenty of time for interaction and questions. So please keep noting any questions or anything that I might say that are not clear enough, and we'll address them after the formal presentation. What we're going to chat about over the next 60 to 90 minutes, diagnosis of schizophrenia today, state of the art. And before I go any further, just disclose my disclosures. I don't have any financial conflicts of interest, but I did work on DSM-5 and the text revision of DSM-5, the work groups in psychotic disorders. And I am a member of the current DSM-5 Serious Mental Disorders Review Committee. But the most important perspectives that I will likely bring to bear on the presentation are my role. I've been a treating physician, a treating psychiatrist for over 45 years. And I bring to my thinking that of a traditional clinician. I want to help people get better, and I will do everything and anything that I can to help them get better. I like things presented to me in a simple manner, straightforward manner, no hand waving, give me hard facts, because I want to apply any information I get to the care of the next patient who walks into my door. And so that's my clinician bias. And as a researcher, I've been researching schizophrenia for about 40 years. And as a researcher, I look for data, information, all available data, and you try and make sense of it. So those are my disclosures. And in addition to my work on DSM-5, DSM-5 text revision, and my career-long interest in psychiatric classification and diagnosis, I do want to point out another source of information that has contributed to this presentation. Cures, in fact, is one of the sponsors of an important international project reconceptualizing schizophrenia. This is an ongoing project. It's been going on for 4 years. It involves the 51 top experts in schizophrenia in the world, and it's the multiple phases of this particular initiative. And these are you don't need to spend any time on this, but this is the list of international schizophrenia experts. You probably recognize a fair number of them. About half of them are from our country, and the others are mainly from Europe, some from Asia, some from Africa, but mainly from the United States and Canada. And part of this international endeavor project, which is ongoing, as I mentioned, is we are currently organizing a series of mini colloquia. We've had the entire group get together. Now we have some, anywhere between 15 to 18 of the experts get together to address specific topics in schizophrenia. And one that we had in June was on updating diagnosis of schizophrenia, in which we addressed a whole range of issues in terms of the diagnosis of schizophrenia. Well, what is the current diagnostic system? And as you probably know, there are two major systems of diagnosis. One is DSM, which is what we use in this country, and ICD-11, which is an ICD, the International Classification of Diseases, which is a World Health Organization classification system that's used around the world. And so we spoke about uh, what the current criteria are. Uh, we spoke about the possibilities of a biological diagnosis of schizophrenia based on causes, based on pathology, based on treatment response, uh, thinking of schizophrenia not as a unitary condition, but or a category, but thinking of it from a dimensional perspective or as a spectrum. And we had a discussion about the role of artificial intelligence in potentially improving our ability to diagnose schizophrenia and improve the criteria by which we do so. And then we also spoke a little bit about early recognition of this condition and interventions that might prevent progression in this condition. So this is what informs what I'm going to share with you. And so essentially, as we think about our current diagnosis of schizophrenia, how do we diagnose schizophrenia? And what does that tell us? And what might the limitations be in terms of diagnosis? Obviously, one diagnoses a condition to describe what the challenges are, what the symptoms are, what difficulties in functioning might be, uh, and to identify the cause of that particular dysfunction, and really define a particular part of the body, excuse me, or the brain that may not be functioning well, that leads to those symptoms, if you will. So essentially, when we think about diagnosis, well, what are we diagnosing? We're diagnosing schizophrenia. So exactly what do we know about schizophrenia today? And then we get to the diagnostic criteria and see how well they relate to what we know about schizophrenia today. So if one thinks about the clinical nature of schizophrenia, the symptoms of schizophrenia, it's not just delusions, hallucinations, paranoia, suspiciousness. Though that cluster of symptoms is what we call positive symptoms. But there are prominent negative symptoms: lack of motivation, reduced social drive, reduced ability to express emotion, reduced ability to experience emotion, cognitive symptoms, broad impairment of a whole range of cognitive functions, the ability to memory, ability to learn, attention, etc. And then mood symptoms are not uncommon in schizophrenia, very common in schizophrenia, disorganization, motor symptoms. So there are multiple psychopathological dimensions in schizophrenia. It's not just one delusion, hallucination, if you will. And that's an important fact that we've learned about schizophrenia, or should I say, relearned about schizophrenia over the past 20 to 30 years. The illness tends to begin in late adolescence or early adulthood. This is when we can first diagnose it. However, although we can first diagnose it generally in late adolescence, early adulthood, a little later in women than in men on average, it's preceded, this initial psychotic symptoms are preceded by what we call a prodrome, which can last up to, on average, it lasts about 5 years, can last anything from 1 to 10 years. It's not identical in all persons with schizophrenia. Not all persons with schizophrenia who go on to develop schizophrenia exhibit this prodrome, but this is generally what one sees. And some degree of premorbid dysfunction even before the prodrome. Once the illness begins, it tends to be, there's a high likelihood that it will be a chronic condition, which gets better and worse, remissions and relapses. And the remissions, when you're better, often you're not completely better. All the symptoms are not necessarily gone. But again, there is significant variation in terms of how it presents itself. The outcome can range from complete recovery to progressive deterioration. So there's a wide range in outcomes. There's a wide range spectrum in which it can present itself. Different persons with schizophrenia exhibit these different symptom dimensions to differing extent. And in fact, the same person at different points in the course of the illness may exhibit different degrees of these dimensions. So that's an important thing to keep in mind, that essentially this is the broad characterization of schizophrenia, what we know. But in terms of how it presents itself in a particular person, there's a whole range of possibilities, and that can change over the course of the illness. So we'll come back to this when we come to diagnosis, because that can be a challenge with regard to diagnosis. So these are the dimensions of schizophrenia, and this is an important thing that we've learned. And actually, in both DSM-5, which is the current version of DSM, and ICD-11, which is the current version of the international classification system, these 6 dimensions have been uh, clearly noted and are very important in characterizing schizophrenia, the expression of schizophrenia in different persons. Positive symptoms, delusions, hallucinations, paranoia. Negative symptoms, lack of motivation, reduced social drive, emotional blunting, disorganization of thinking and behavior, a broad range of cognitive deficits, prominent mood symptoms, and motor symptoms, of which catatonia is the most extreme. Now, why is this an important fact to keep in mind? The fact that there are these 6 different dimensions of schizophrenia, because the underlying brain pathology, the underlying circuitry uh, for each of these symptom domains is different. And even more importantly, from a clinical perspective, these 6 symptom dimensions respond differently to treatment. So when you think about the main treatment of schizophrenia, it's medications, it's a group of medications called antipsychotics. Antipsychotics work pretty well for positive symptoms and pretty well for disorganization. They don't do anything for negative symptoms or cognitive deficits, and they can both help and hurt, improve or worsen mood symptoms and motor symptoms. So we use antipsychotics to treat depression, but antipsychotics can also cause depression, something we call neuroleptic dysphoria. Catatonia, as I mentioned, is the most extreme form of motor dysfunction. Antipsychotics can treat catatonia, but they can also cause the worst kind of catatonia, neuroleptic malignant syndrome. So you can see that when we make a diagnosis of schizophrenia, it's very important to take the next step and describe how that schizophrenia is appearing in this person sitting in front of us, whom we've diagnosed with schizophrenia. What is the distribution of these symptoms across these 6 dimensions? And then when we begin treatment, it's important not just to say, oh, the person's getting better or getting worse. Well, it's important to specify which of these dimensions is getting better, which is not getting better, which may be getting worse in the course of treatment, and then make appropriate treatment decisions. So this is a very important uh, element in terms of characterization of schizophrenia, the measurement of the different dimensions of schizophrenia in persons whom we diagnose with schizophrenia across during the course of treatment. And this is the usual course of schizophrenia. So what else do we know about schizophrenia today? So we've discovered causes of schizophrenia, not one, not two. In terms of genes, we've discovered several hundred risk genes for schizophrenia, more than 300 different gene variants that increase the risk of schizophrenia. We know there are a whole range of environmental factors, uh, you know, first trimester infections, uh, uh, child, uh, childhood abuse, cannabis use, a whole range of environmental factors that increase the risk of schizophrenia. So we know there are multiple causes of schizophrenia. We know that multiple brain regions are affected in schizophrenia. Multiple aspects of development are affected in schizophrenia, whether it's excessive synaptic pruning or whether it's myelination. There are a number of different aspects in terms of the development of the brain that are uh, affected in schizophrenia, that are different in schizophrenia. There are multiple circuits that malfunction in schizophrenia. And as I mentioned earlier, there are different circuits that appear to underlie different symptom dimensions. In terms of treatment, antipsychotics are the mainstay in the treatment. They're fairly effective. They work across they don't work exactly the same in all patients. Secondly, as we discussed earlier, they work better for some aspects of the illness and not quite as well for others. And psychological social treatments are valued. So this is what we know. But the reality of schizophrenia today is, although we have made significant advances in our understanding of schizophrenia, we still don't have a lab test, a diagnostic test for schizophrenia. If this chemical is abnormal, that means it's schizophrenia. Or if this a brain scan shows this must be schizophrenia. So we don't have that. We don't have a diagnostic test. We don't have a necessary or sufficient pathology or etiology. And this is despite the fact that we've made significant advances in our ability to look at the brain, to research the brain, and we've got really brilliant scientists trying to better understand, elucidate the nature of schizophrenia. And if one looks at the reality of schizophrenia today, in addition to there not being any specific diagnostic test, our treatments have gotten better, but the improvements have been relatively modest, and outcome is certainly better today than it was, say, 75 years ago. But again, the improvements in outcome are relatively modest as well. And this is something for us to keep in mind. There's still some ways to go to improve outcomes for persons with schizophrenia. So, what does this all tell us? Well, schizophrenia doesn't look the same in all people who are diagnosed with schizophrenia. What the causes might be would differ across people. Exactly, the pathologies could differ. How it's clinically expressed, severity of different symptom dimensions would differ. How they respond to treatment would differ. And so, what is all this is telling us is that schizophrenia is not one disease. There are multiple causes, multiple pathologies, and the pathology itself and yeah, the causes overlap with other diagnostic entities. There are probably hundreds of schizophrenias, if you will, hundreds of different disease conditions that are part of what we call schizophrenia. And yet, we've not been able to precisely differentiate between these hundreds of schizophrenias, if you will. So we call the whole thing schizophrenia. So one might wonder, okay, so if it's not one disease, if it's many different conditions, why do you even want to make a diagnosis of schizophrenia? Is it useful? And the fact of the matter is, yes, when you make a diagnosis of schizophrenia, it gives you a fair amount of information. Now, it's not as though all this information applies 100% to everybody who we diagnose with schizophrenia. But what a diagnosis of schizophrenia tells you is there's a particular course, there are these different symptom dimensions, there's a range of pathologies, and if you intervene early, you can limit the amount of deterioration that this condition tends to have a remitting, relapsing nature, and preventing relapses are a very important part of helping persons with this condition. And there are very specific treatment implications. So, despite the fact that it's not a singular disease entity, make a diagnosis of schizophrenia still provides very useful information about what might be happening in this person who's experiencing distress, symptoms, having difficulty functioning, and it gives guidance to what the best treatment might be. So, with this, how do people diagnose schizophrenia today? When you go to your doctor, how does he or she make a diagnosis of schizophrenia? Well, they get a history, they examine the person, and then this is how they diagnose. They say, well, psychotic symptoms should be present for some time. How long? Well, it's not for hours or days. They should be present for weeks to months to years. Now, different psychiatrists, have a different threshold with regard to how long they need to be. The longer, the more likely it's to be schizophrenia. But is a month or two long enough? Or does it have to be 6 months or more? Does it have to be years? I mean, that varies. So and different diagnostic systems have different minimum durations, if you will. But one of the things that clinicians uh, count on, one criterion is psychotic symptoms must be present. Secondly, mood symptoms must be absent. Now, again, here different psychiatrists differ in terms of how they practice. Some psychiatrists require absolutely no mood symptoms, no depression, no manic symptomatology to be present. Others say, some can be present, but how much is too much before you say this is not schizophrenia? That varies across different psychiatrists. And is there a need for some degree of decline or deterioration in socio-occupational function? Different psychiatrists, again, uh, you know, pay different degrees of importance to this particular criterion. All psychiatrists are very careful to exclude any organic etiology. Now, substance use can often coexist with schizophrenia, but substance use, certain substances in particular, if you're intoxicated with them, then you will have psychosis because of that intoxication. Other substances, when you're withdrawing from them, you can have psychosis. Like when you're withdrawing from alcohol, for example, you can have hallucinations. So, but the psychosis which is present should not be explicable. You shouldn't be able to explain the psychosis on the basis of substance use or some other brain condition, if you will. And then, that's how they diagnose it, and then they proceed with treatment. When we ask most clinicians, so are you using diagnostic criteria? Are you using DSM or ICD or any of this? Uh, most of them, if they're honest, will say, loosely, not very rigorously, loosely, because again, uh, we know it's not one disease condition. We know it's not a singular condition, and so using criteria loosely, is good enough, if you will. Uh, and in any event, we're treating symptoms, not a diagnosis. There's so much heterogeneity. And so these are some of the things that clinicians might say if they're fully honest in terms of how they're making a diagnosis. And so the question we should ask, and I ask myself, my trainees, and other clinicians, is this really the best we can do? Is there anything that DSM-5 and or ICD-11 offer that might help us in terms of better diagnosis that will help us better treat persons we diagnose with schizophrenia? And so this is DSM-5. And I, again, to remind you, maybe a potential, it might impact the way I look at it. The fact that I spent about 4,000 uncompensated hours working on this. And I wasn't the only one. There were others as well. And so hopefully, we all hope that our work has some value. And so there might be a bias, if you will, that might be reflected in my comments. So what were we trying to do when in DSM-4, the prior version, if the treatment of schizophrenia had been good, had been satisfactory, we wouldn't want to change it. But the problem was in DSM-4, the boundaries with other condition were somewhat fuzzy. Uh, where does schizophrenia end and where does schizoaffective disorder begin, for example? A question. And folks did not seem to have the same diagnosis over time. They were diagnosed as having schizophrenia at one point. Then a few months later, the diagnosis was changed to schizoaffective disorder. Then a few months later, it was changed to bipolar disorder with psychotic features. And then a year later, changed back to schizophrenia. So there was variable diagnostic stability that reduced the clinical utility of diagnosis. And lastly, there was enormous heterogeneity, variation, variability in schizophrenia, for example. Now, one of the things to keep in mind is in DSM-4, we try to account for this variability by by calling them by having subtypes. Excuse me, is there someone whose phone is not muted? Who's please mute your thing so that we can get through the presentation and then we'll have Q&A. Uh, so essentially, uh, we had subtypes, but the subtypes did not capture this extreme variability. So these were some of the problems that we needed to address in DSM-5, which we did. And these were some of the changes we made. I want to highlight a couple that are really important. The first is we provided in DSM-5 a specific definition for psychosis itself, differentiating what we call the core features of psychosis: delusions, hallucinations, severe disorganization of thinking. Uh, One of these must be present to say you've got psychosis. You must have one of the core symptoms before you say someone has psychosis or a psychotic disorder. And schizophrenia is a psychotic disorder. But there are other features. The accompanying features are also very important. And these are the accompanying features. And these accompanying features, uh, basically, there's relative severity and how their chronicity uh, with essentially is relevant to making a diagnosis of what the cause of the psychosis is. Is it schizophrenia? Is it schizoaffective disorder? Is it delusional disorder? Is it bipolar disorder, manic with psychotic features, etc.? So one of the core features, the three core features must be present to say psychosis, but the other accompanying features are also very important targets of treatment, and they help with differential diagnosis. And again, uh, six dimensions, as we mentioned, uh, positive symptoms and disorganization being core dimensions, and the other four being accessory dimensions. But the important thing here is one of the things we did in DSM-5, which unfortunately is not being practiced, not being utilized, is we provided a simple instrument to measure the severity of those dimensions in persons diagnosed with a psychotic disorder. And you should keep measuring them, each of these dimensions, as you treat persons. So, for example, hallucinations and delusions are positive symptoms. Disorganized speech disorganization, abnormal psychomotor behavior, catatonia, motor, negative symptoms, cognition, and depression and mania, two aspects of mood. Now, very simple instrument. It takes a few minutes, a couple of minutes to administer this instrument, but measuring what is happening to these six dimensions in the course of treatment provides a useful guide as to what one needs to do next to help the person whom one is treating. So, for example, you use antipsychotics. Well, the positive symptoms get better, but if the negative symptoms get worse, well, that points to a certain occurrence that you can treat with specific medications. If, in fact, depression, generally, as positive symptoms get better with treatment, mood symptoms get better too. But if positive symptoms get better, delusions, hallucinations get better, and depression continues, severe depression continues, then one adds an antidepressant. So there are very specific implications to the pattern that one sees in the course of treatment with these different dimensions. So it provides the ability to provide individualized targeted treatment, and that is important. What about schizoaffective disorder? This was a challenge. And one of the things to keep in mind is this is one of the areas where ICD and DSM were found to be very, very different. In DSM-4, what we would call schizoaffective disorder in DSM-4 would generally be called schizophrenia in ICD, and what we called uh, and what is called schizoaffective disorder in ICD would generally be called psychotic mood disorder in DSM-4. So again, there was a big difference. This difference has been substantially decreased, and we've provided a more specific definition for schizoaffective disorder that the mood symptoms, prominent mood symptoms, need to be present for at least 50%, more than half, the duration of the psychotic symptoms for one to diagnose schizoaffective disorder. Otherwise, it is schizophrenia with mood symptoms, if you will. So, an important distinction. And so, these were some of the changes that were made in DSM-5. Now, one of the things that you might wonder is, okay, so you're talking about schizophrenia, schizoaffective disorder. Does it really matter what you're diagnosing? If you're treating schizophrenia or schizoaffective disorder, aren't you just treating the psychotic symptoms and the mood symptoms, and regardless of what the diagnosis is? And the answer is, well, it does make a difference. Antipsychotics clearly are the foundational treatment for the psychotic symptoms. However, the duration of antipsychotic use, recommended antipsychotic use, would vary. In schizophrenia, it would be much longer term, in some individuals, lifelong. Uh, in schizoaffective disorder, it would be less long term, and there'd be a greater scope for drug free periods. Similarly, the use of antidepressants and or mood stabilizers also would depend on whether it's a diagnosis of schizophrenia or schizoaffective disorder when one uses it. So even if in schizophrenia you have prominent mood symptoms, when you use the mood stabilizer and or antidepressant, and how you use it would be different than if it was schizoaffective disorder. And in terms of the course of the illness, what one can expect, it's more episodic in schizoaffective disorder. So again, the important thing is, there are limitations in terms of our diagnosis of schizophrenia. We recognize it's not a singular disease condition, but the criteria that we have fairly well map on to what we know, and utilizing these criteria can significantly improve the quality of treatment that we provide. And so, getting back to the project that, international project that I mentioned, Cures is one of the sponsors for. Uh, you know, we all agreed, all the experts agreed, the boundaries are fuzzy. It has several psychopathological dimensions, but these dimensions are also not unique to schizophrenia. They're shared with other entities, and the experts disagree about what the precise core of schizophrenia might be. So this is one of the papers that resulted from this activity. Essentially published last year, exactly what we know about the schizophrenia syndrome and how that informs its nature. And note the term syndrome. It's not a single disease, it's a syndrome. One should think about schizophrenia as a syndrome with multiple causes, multiple pathological mechanisms, and really hundreds of diseases that are that can lead to the syndrome, if you will. We just don't know how to demarcate those several hundred diseases that are part of the syndrome. So we treat it as the schizophrenia syndrome. Now, as we move ahead, treatment of schizophrenia today and research into schizophrenia to better understand the condition and develop more effective treatments, we need to accept the reality of what it is. Psychoses, they're not one thing, they're heterogeneous, and there's significant overlap in biology, genetics, outcomes, treatment across different categories that we have. And these different aspects, clinical biology, pathology, etiology, causes, etc., they don't map onto each other. And forcing them to map on to each other is not going to be a worthwhile a proposition. And so it's really important. We've learned a lot about this condition, schizophrenia. There's still more to learn, but we've learned a lot. And it's important for us to accept what this is telling us. And so one thinks about it, schizophrenia is a syndrome. It is not a singular disease entity. And this is the reality of schizophrenia. And so it's important for us to understand that and hence not expect everybody with that we diagnose with schizophrenia to respond the same way. And we can individualize treatment. There are different etiological factors that are relevant in different people we diagnose with schizophrenia, different pathologies, and it's important to recognize that and then identify what the pathology might be in this particular individual, and then individualized treatment, as I mentioned. So, despite the limitations in our current diagnosis of schizophrenia, this is the best we have. We don't have a blood test or a brain scan that tells us this is schizophrenia. We base diagnosis on signs and symptoms, on clinical signs and symptoms, and this is the best we can do today. It's not bad. It's pretty. It's not perfect, but it is pretty good. And clearly, there's nothing to replace it with at this point. But it's important to recognize, again, I repeat this again, that it's a syndrome. And as we think about studying schizophrenia or treating schizophrenia, it's important to recognize this important fact of schizophrenia, that it's a syndrome. And some people say, okay, well, some experts, researchers in particular, and some clinicians say, okay, so, well, if it's not perfect and we know that there's some flaws in it, let's stop diagnosing it. Well, the reality is today, and let's wait till we find out everything there is to know. Well, certainly, as we find out more, we might be able to define it better and provide better diagnostic criteria. But we've got to kind of do something today as well. There are real people with what we call schizophrenia who need help. We need to identify them, and then we know what treatments to provide, how to measure the impact of those treatments. And so, really, that is the need for diagnosing schizophrenia rigorously today, because then we can identify that condition and treat it effectively. And this is what the advice to clinicians is: know the criteria, apply them strictly, and and there are some common mistakes that are made in the application and how to avoid them. So let me stop at this point. Uh, Multiple dimensions of the condition, heterogeneous, a syndrome, not a singular disease, and in terms the six dimensions, there is a very simple scale to assess the severity of these dimensions, and that can enable, if you monitor what's happening to each of these dimensions over the course of treatment, you can provide individualized care. You can provide targeted treatment. So let me stop at this point and take any questions. Thank you for your attention.
Thank you, Dr. Tandon. Thank you for such an interesting lecture this evening. Dr. Tandon, why don't you stop your share, actually? Let's see if I can do it.
I think I did stop the share. No?
Sorry, everybody. Hang with us for, there we go. There we go. Okay, great. Let's look at some of these questions. Can we get a copy of the slides? Dr. Tandon, will your slides be available?
Sure.
Okay. If schizophrenia is genetic, can you test to see which parent passed the gene on?
So if schizophrenia, if there was only one gene, uh, then one could identify, where the gene came from. As I mentioned, there are over 300 risk genes for schizophrenia, risk gene variants that we've identified thus far, and we'd probably identify more. And the amount of risk that they confer is relatively small. Uh, it varies in terms of the incremental risk that each of these risk genes confers. Certainly, one can find out where that particular risk variant, should a person with schizophrenia have it, where that risk variant came from by studying the genome of the parents. But there's little value in doing that because the incremental risk, if one has one risk gene for schizophrenia, then it doesn't mean you're going to have schizophrenia. You probably need multiple risk genes or multiple risk genes interacting with some environmental factors that lead to schizophrenia. So right now, having one of those risk genes doesn't mean you're going to have schizophrenia. Having one of those environmental risk factors doesn't mean you're destined to have schizophrenia. So that's an important thing to keep in mind, that at this point, getting which parent gave what particular risk gene is of relatively little value. I see a whole bunch of questions. Should I just take them on, Bethany?
Yes, you're welcome to do that.
Okay, okay. So do I- so uh, well, let me start. Can we get a copy of the slides? Absolutely. Uh, if it's genetic, can you test which parent? Yeah, so as we addressed that. Along with meds, would occupational therapy assist in recovery? And the answer is yes. One of the things, again, the way it expresses itself and how it affects individuals varies across people. And so varies across persons with schizophrenia. But one of the common symptoms is reduced motivation, reduced social drive, and occupational therapy addresses that particular, a good occupational therapy. And that too can be individualized to facilitate, to improve the likelihood that a person with schizophrenia can function uh, can function better, can can be employed, can be productively employed, if you will. Are there different types of schizophrenia? So again, well, there are different schizophrenias, but we don't know. So we used to have subtypes of schizophrenia before, paranoid, catatonic, undifferentiated, uh, disorganized, etc. But that subtyping was not helpful in providing more specific treatments, etc. So essentially, the question about can someone have a can someone have schizophrenia without paranoia, but uh, hallucinations? And can paranoia develop earlier? Absolutely, that can happen, and that is schizophrenia. So now, this is a really good question, the analogy with breast cancer, for example. So, so say someone has breast cancer. Absolutely, here, breast cancer, there are certain genes that basically indicate that, uh, the cancer cell is responsive to hormonal treatment, Herceptin, for example. And so again, there's value to getting the kind of gene analysis done. The challenge with schizophrenia is twofold. One, the incremental risk associated with a single gene variant is very small, relatively small, very small, really 0.05%, that kind of thing, or up to 0.5%, but for some of the very rare variants. Now, the other challenge is, well, even if you identify a particular gene variant, exactly how that gene variant leads to brain pathology which in turn leads to schizophrenia, we don't understand yet. So we don't know the pathway. And so if you can identify a particular gene variant and you say, well, even though the incremental risk might be small, can I do something about it? And the answer is, well, uh, doing something about it. There's nothing we don't know exactly what you should be doing about it. And so those are the two challenges. As we address those challenges, I'm hopeful we will over time. Then there would be value to this. Uh,
Dr.
Now,
Tandon, Maureen has her hand up. Maybe we can get some interaction from our
sure, let's do
viewers.
that. Absolutely, let's do it.
Maureen, why don't you unmute yourself and speak?
Unmute. Hi, thank you for taking my question. Do you have an opinion on the drug Cobenfy, particularly with how it's handling the negative symptoms? My son's currently hospitalized and they're debating Cobenfy or clozapine. So he's not psychotic. It's the negative symptoms, anhedonia, depression, catatonia. Like he's not living.
I hear you. So actually, Cobenfy is the first medication that does not work on a chemical dopamine, if you will.
Mhm.
And, this might sound immodest, but, this is the system that I did most of my work on, the muscarinic cholinergic system, going back 35 years. This was my major area of interest. So the question is, what does Cobenfy do? How does it differ or not from other existing antipsychotics? And the challenge is there aren't very many long-term studies with Cobenfy. All the studies with Cobenfy have been 5-week duration. And when you're thinking about an illness, like schizophrenia, you would like longer term data. The second thing about Cobenfy, so I'm excited about Cobenfy. So I just want to share with you, it's the first medication which doesn't work on dopamine that's been approved for the treatment of schizophrenia. So it's exciting. But the second challenge with Cobenfy, it's not been compared to any existing antipsychotic medication. So how the clinical effects differ, we don't exactly know. We can only infer, okay, we've used it, Cobenfy, we've seen this, compared to sugar pill with Cobenfy, compared to a sugar pill, this is what clozapine does. Compared to a sugar pill, this is what risperidone does. So this is probably what Cobenfy will do, but it has to be compared directly head to head. So getting back to the question of prominent negative symptoms, one would need a lot more clinical information about your son to kind of provide any better guidance, a little more intelligent guidance, if you will. But what I would say is, when you think about clozapine, the main benefit of clozapine is in refractory positive symptoms, refractory delusions, hallucinations, paranoia. It doesn't do much for refractory negative symptoms unless unless those negative symptoms are related to persistent positive symptoms, or they are related to Parkinsonian side effects. And so that's important. Then clozapine or Cobenfy could be of value. I mean, but I would try clozapine before Cobenfy because we know a lot more about clozapine than Cobenfy. But if it's just negative symptoms in the absence of any positive symptoms, and it's not because of Parkinsonian side effects, then it's unlikely that clozapine will have a significant benefit.
Let me take another question from the chat and then we'll go to Arturo. But someone has asked, Kathleen actually has asked about if there's a need to collaborate with a neurologist when diagnosing or treating schizophrenia.
Not necessarily. I mean, essentially, in contrast, so again, we both deal with the brain. Psychiatrists deal with the brain just as neurologists deal with the brain. So what's the difference, if you will? And if I was to give you a, somewhat loose example of the difference, it's like the hardware software difference. Neurologists deal with hardware, Psychiatrists deal with software, if you will. We deal with circuitry. Neurologists deal with lesions, if you will, hardware, if you will. The only so when might I engage with with a neurologist? Well, if there's some real question about a uh, hardware problem that I'm concerned about, that needs to be addressed, then I will involve a neurologist. But otherwise, not really. In terms of diagnosing schizophrenia, there's relatively little value.
Arturo, why don't you unmute yourself and speak up?
Yes, hi, thank you. And that was a great presentation, very informative. Anyway, thank you. I had a question about cannabis use and synthetic marijuana.
Yep.
I have a son who's been diagnosed with schizoaffective disorder, and it was very sudden. And we know that there was synthetic marijuana involved, possibly LSD, and some cannabis use in the past. And in addition, right, I mean, so there's the first question is synthetic marijuana, and the second one is cannabis, which is not the stuff back from the 1960s or 50s that people grew their little plants. It's very different today. So I'm wondering, if you observed any trend of increased psychosis, schizoaffective disorder, people falling maybe even into schizophrenia because of the synthetic marijuana, enhanced, if you will, cannabis at all. Is that something you've observed? And do you have any insight? Is that a trend?
No, that's a great question. So we have not observed a trend of increasing diagnosis of schizophrenia related to uh, synthetic cannabinoids or even the higher potency THC cannabis that you see these days. So we've not seen uh, it translated to an increased incidence occurrence of schizophrenia. However, there are two or three things that are relevant here. One, in certain locations, for example, in
Yes,
Southeast London, for example, they have observed an increase in the diagnosis of schizophrenia, which is actually related to cannabis use, significant cannabis use in a particular subpopulation in Southeast London. So that's a fact in terms of the incidence. And there used to be a huge debate about whether or not cannabis could cause schizophrenia, or cannabis just made schizophrenia look worse or different, but it didn't really cause schizophrenia. And now the debate is more or less closed. It can cause schizophrenia. It increases the risk of schizophrenia. Clearly, it does. Now, why we are not seeing the expected increase in incidence of schizophrenia with a higher potency of cannabis, it's difficult to kind of speak to. But in terms of actual broadly, we don't see this increased occurrence.
Thank you.
Kathleen asked, how do you feel about a patient taking both risperidol and ESG at the same time?
ESG.
I don't know ESG. Kathleen, are you with us? Okay.
Yeah, yes, I am. I just, that's the abbreviation I know, but I'm gonna run down my hall and go get the bottle so I can spell it
Okay.
all out. It's a long name. I'll be
Sure, no
right back.
worries.
Okay, we'll
Sure.
keep going in the meantime. Let's see. Oh, Ellen had a question. I had no idea medications could be stopped when in remission. I'm not sure Dr. Tandon said that. She says, I thought it was
Great question. So, no, I did not say that. I did not say that medicines could be stopped when you're in remission, because one of the things we know in schizophrenia, so there are a couple of paradoxical things that you see. In schizoaffective disorder, there'd be a little greater likelihood that you could stop medication. You could try when the person is well. You could try with under observation, medication free. In schizophrenia, there are two paradoxical things. One, it doesn't matter how long you've been stable. If you've been doing well for years, but you stop the antipsychotic medication after say 5 years or 7 years, the risk of relapse is about the same as if you stop the medication after a year of stability. So again, there is that risk of relapse, which is a reason why you don't want to stop medication. At the same time, about 20% of persons with schizophrenia do pretty well without medication. And so the question is, can we identify that 20%? And the answer is no. And so this is a challenge that, as a clinician, on the one hand, we know there's this very high risk of relapse, but there is also 20% who will do well without medications, which we can't identify. So if my patient basically insists, doc, I don't want, I'm not taking it, I'm not taking it, I'm not taking it, I will have this discussion with him or her. I will have this discussion about risk, about likelihoods, about my suggestion. Uh, and then if he or she insists, I am stopping it, doc, then I'm going to suggest, okay, so let's stop it, but let's do it gradually. And let's keep monitoring how things are going. If things go well and continue to go well, great. But if they don't, then we may have to get back on medication. So again, it's working collaboratively now. So again, 80% chance of a relapse, but 20% you won't get it. And it doesn't matter how long you've been stable, that doesn't modify this ratio, if you will. And schizoaffective disorder, on the other hand, again, you know, if you made a careful diagnosis, a strict diagnosis of schizoaffective disorder, then in that case, during periods of stability, you can have a little less concern about discontinuing medication. Ms. Stern, go ahead. You had your hands up, so go ahead.
Yes, sorry, I said ESG. It's actually ESC, which is acetalopram, ESCITALOP.
Escitalopram. Oh, yeah.
Yeah.
So, okay. Escitalopram, or yeah. So again, escitalopram is a antidepressant, and so yeah, you can take escitalopram and risperidone together. Now again, one of the things that I would always ask my doctor is, Doc, what is the risperidone for? Doc, what is the escitalopram for? And they'll probably tell you, well, the risperidone is for psychosis, delusions, hallucinations, and the escitalopram is for depression. And so the next question I would ask my doctor is, well, Doc, how do you know that he's getting the right amount of risperidone, right amount of escitalopram, if you will? How are you measuring depression, response to depression, and psychosis? So those are the questions I would ask. Yeah, but the combination is safe. Again, it depends on the dosing. It depends, again, when I say it's safe, different people respond differently to medications. And so it's important to monitor how this person is doing.
Okay, thank you.
Why don't we, okay, we've got 3 questions up. We'll take at least 2 and then we'll close. Deborah, you are first. Why don't you unmute yourself and go ahead?
Thank you. So my question that I put in the chat, and really about your 20% comment about not taking medication, might be kind of related, because you know, there are a significant number of people, I don't think, that connect with the symptoms and the course of treatment, and then just, you know, don't seem to have awareness. Some people think anosognosia is actually a thing, and other people think it is not. They just haven't gotten awareness yet. But then I hear you saying like 20% of the people maybe can not have to take medication. And I assume then don't become a danger to self or others, or become gravely disabled. They're able to kind of function, at least at some level, with reality testing or maybe support, something like that. So can you speak to the 20%, what that looks like?
Sure. So the first thing is, anosognosia is a very real thing. I mean, it's a very real thing. It's an unfortunate thing because you don't think there's anything wrong. You don't think you're unwell when you're clearly unwell. I mean, so it's sad. It's a difficult symptom. Now, as far as the 20% is concerned, the challenge is identifying if you're on the 20% or 80%. And that's the challenge. We don't have an ability to do it right now. It's not that we've not been trying. This is something we've known for decades, actually, that there is about 20% of individuals with schizophrenia who do okay without medications, they don't relapse. But what we've not been able to find out any particular test or mechanism of identifying them. The only way to do it is stop the medication and see what happens. And there too, you don't necessarily see a relapse right away. You might see a relapse in a few months. So the critical thing there is to keep monitoring. You keep monitoring, keep monitoring, keep monitoring. And again, I would like to play the odds in that, 80% versus 20% to me, as long as the medications are reasonably well tolerated, you know, I take the odds of, I don't want to take a chance of the eight, because one of the problems with a relapse is once you relapse, then it may, the same medication that worked before might not work again. And so there are downsides to taking that chance, if you will. And so again, but I would work with the person. I mean, obviously the person I'm going to stop, well, okay, let's stop, let's work on this together, so to speak.
I think we should let Dr. Tandon go. It's 7:02. Thank you all so much for joining us. If you have further questions that haven't been brought up tonight, feel free to email me and I will try to find an answer either from Dr. Tandon or from another expert. So thank you for joining us and good evening.
Thank you so much.
Thank you.